This conference will now be recorded.
Good morning, everyone. Today, the topic of discussion is on cerebral venous thrombosis. Previous class, we have discussed some spinocerebellar ataxias, how to approach ataxias, and before that, we have discussed cord compression, spinal cord disorders, and we also discussed that midbrain pons medulla anatomy, brainstem, anatomy of the brainstem and lesions, and corticospinal tract anatomy, physiology, and as well as and lower motor neuron lesions. Now today we will discuss cerebral venous thrombosis, right? Cerebral venous thrombosis is also called is the thrombosis of the dural sinuses or cerebral veins, right? So dural sinuses means can anyone name the sinuses? What are the sinuses in the brain, you know? Can anyone please tell me the sinuses? Sinus. Venous sinus. Venous sinus. Venous. Don't tell frontal sinus, maxillary sinus, ethmoidal sinus. Okay. Please tell me the venous sinuses. Okay. Yeah. Tell me.
Cavernous sinus,
Okay. Cavernous sinus.
superior sagittal sinus,
Superior sagittal sinus. Okay. So it's the thrombosis. Cerebral venous sinus thrombosis is the thrombosis of dural sinuses or cerebral veins, right? Also called as cerebral vein thrombosis, cerebral venous and sinus thrombosis, cerebral venous sinus thrombosis (CVST), cerebral sinovenous thrombosis (CSVT), cerebral vein and dural sinus thrombosis, sinus and cerebral vein thrombosis, right? So these are all the names you can call for cerebral venous thrombosis, right? So this is the superior sagittal sinus, right? This is the superior sagittal sinus, and this is the straight sinus, right? This is the straight sinus. This is the transverse sinus. Okay. This is the straight sinus. This is the transverse sinus. See, please remember, this is the superior sagittal sinus, SSS. This is the superior sagittal sinus, superior sagittal sinus. This is the straight sinus, straight sinus. This is the transverse sinus, right? So the superficial cerebral venous system consists of the cortical veins, superior anastomotic veins. There's a vein of Trollard. It drains into the superior sagittal sinus. So this is the vein of Trollard. Vein of Trollard. Neat entrance examination. Vein of Trollard. Very fond of giving these veins. Vein of Trollard, vein of Gallen, vein of Lebbe. Right. Everyone will be fond of reading, and everyone will go, and everyone before going to the neat entrance examination or any examination, you will be knowing the superior sagittal sinus is here, straight sinus is here, transverse sinus is here, but they will be asking the vein of Trollard, vein of Gallen, vein of Lebbe, A, B, C. Okay, they will ask you A, B, C, and they will give you the which of the following is right or which of the following is false. And so you please remember, this is vein of Trollard, vein of Gallen, vein of Lebbe. So this Trollard drains into the superior sagittal sinus. Okay, this Lebbe into the transverse sinus, and this is into the straight and inferior sagittal sinus, right? So deep vein system comprises of the basal vein of Rosenthal, which is the vein of Gallen, right? This is the deep vein system, vein of Gallen. It drains into the inferior sagittal sinus as well as the straight sinus. Okay. Will you please remember this image for your at least till you get your neat entrance examination or in enhanced Ames, JIPMER, PGA, right? So superior sagittal sinus, straight sinus, transverse sinus, vein of Trollard, T. Vein of Trollard is high. Okay, right. Vein of Gallen, deep. Basal vein of Rosenthal. Okay. This is vein of Lebe, transverse sinus, draining into the transverse sinus. Okay. So here there will be the cavernous sinus, right? So this is the cavernous sinus, right? This is the cavernous sinus. Okay. So CVT is the uncommon form of stroke. This is not that much common, right? So what are the common causes of stroke? We have discussed it, right? In the previous session, we have discussed the common causes of stroke. Basic common cause of stroke. What may be the risk factors for stroke? Please, someone answer. Simple question. What are the risk factors for stroke? Please. Risk
High
factors for
blood
stroke.
pressure.
Yeah.
High blood pressure.
High blood pressure. What you will call for high blood pressure? Hypertension. Okay. Please don't tell the language which we not use in the books. Right? High blood pressure is okay, but please tell hypertension, right? Hypertension. Any other causes? What are the causes of
Anesthesia.
stroke in men? Okay.
Smoking, sir.
Amma?
Smoking,
Hello.
sir.
Yeah, smoking is also risk factor. Okay. What are the causes of stroke in young? Many times discussed this thing in clinical wards,
Kidney.
right? No. Stroke in young patients. See, hypertension, diabetes mellitus, and smoking, risk of atherosclerosis leading to the stroke. These are the risk factors, right? And most commonly, we will see after the age of 45 years or 50 years, right? But before age of 40, 45 years, right? Some patients may presenting with stroke, right? Some patient may present with hemiparesis, right? Hemiparesis. I am telling about hemiparesis only, not paraplegia, right? Paraparesis you may see in young patients also because hypokalemic periodic paralysis. You will see patient in the previous day when going to the party and eating a high carbohydrate diet, so leading to shift of potassium. So deficiency of the potassium may lead, and the patient may be having a genetic defect of channel defect. So channelopathy, hypokalemic periodic paralysis presenting next day to the casualty with paraparesis, bilateral weakness of the lower limbs, right? So, and patient having high carbohydrate diet, maybe having some genetic defect, right? So, shift of potassium, sudden deficiency, acute deficiency of potassium. So, leading to hypokalemic periodic paralysis. If you give potassium 2 ampoules KCl and 500 ml NS for 2 hours, then the potassium will be corrected. So patient paraparesis will be also be corrected, right? So this we will see in young patients, right? So that is paraparesis. Now I am asking about stroke in young. What are the causes of stroke in young? Many times we have discussed in the wards, right? What are the causes of stroke in young? Answer, please answer. It was 7th. Yeah, I remember. Many times I've asked this question. What are the causes of stroke in young? Hypercoagulable disorders, right? Do you remember hypercoagulable disorders? Protein C deficiency, protein S deficiency, antithrombin 3 mutations. Okay, homocystinemia. These factors, these risk factors, you may see patient may be presenting with stroke, and you should go for thrombophilia, thrombotic profile is nothing but protein C, protein S. We will see the levels of, and this antithrombin mutations, protein S deficiencies, right? And also this homocysteine levels. So some of the thing may be deficient, protein S deficiency may be present, or protein S deficiency may be present, and maybe patient will be also having some hyperhomocystinemia. These may be the risk factors, and these may be the causes of cerebral venous, so not cerebral venous thrombosis, for stroke in young, right? So cerebral venous thrombosis is an uncommon form of stroke. It accompanies for 0.5 to 1% of the strokes, right? Frequently unrecognized. We can't recognize it is real if the patient comes with the hemiparesis, weakness of lower right upper limb and right lower limb. We think of that as a ischemic stroke or hemorrhagic stroke, maybe whatever may be the stroke, but we will think about some ACA territory or MCA territory, PCA territory. We have already discussed MCA territory, ACA territory, PCA territory. ACA is anterior cerebral artery territory. So what happens? Lower limb weakness is greater than the upper limb weakness, right? MCA territory, the patient will be presented with aphasia, right? Aphasia, MCA territory. superior division, inferior division, posterior cerebral artery, visual hallucinations. Okay, so coming to the cerebral venous thrombosis, we can't recognize the things. Why? Because there will be some weakness will be there, but we can't say that it is a venous thrombosis, or we can't say there is arterial thrombosis and what type of stroke the patient has occurred. So it is difficult to recognize, and this is the challenging thing. If you recognize it as a cerebral venous thrombosis in case of in casualty, and you make a differential diagnosis of CVT, and you go for MRI, MRB, MR venography, and if it is there any thrombus in the superior sagittal sinus, a transverse sinus, or straight sinus, then your diagnosis is correct. And that is the challenging part if you diagnose these type of cases, right? So diversity of the causes, and there are many presenting scenarios are there for this CVT, right? And young patients, we will see more young, 70% less than 15 years are old, right? 70% of the patients will see present CVT of age less than 50 years, right? And this one, females is to male is 3 is to 1, right? See, everyone seeing this? Female is to male ratio is 3 is to 1. Actually, this is the thing. Textbook Harrison and every other standard books, gold standard books gives this actually. Yes, okay. And I did the paper on this cerebral venous thrombosis. I did a paper on cerebral venous thrombosis, and I presented in the national conference, right? And my results are nothing but males. I took only 40 patients. I had done only on 40 patients, right? And out of 40 patients, 24 patients are males, right? And that is the thing I want to prove, that nowadays and cerebral venous thrombosis is also occurring most commonly in males, right? And that is my paper. So males, we can't say this females to males ratio is 3 to 1 every time, right? That's what I want to say here, right? And the most common cause why males are getting CVT is that the most common cause for males is alcohol, right? Alcohol may also cause CVT, cerebral venous thrombosis. Alcohol cause acute dehydration, right? And that causes CVT, right, acutely. So pregnancy in females, the most common cause is pregnancy and postpartum, right? And oral contraceptive pills, right? So in my study, pregnancy very less, and postpartum out of those 16 cases, postpartum are 10 cases. OCPs are 2 to 3 cases I have seen, right? So can lead to the okay, CVT leads to significant mortality and morbidity, right? So please remember these points. Uncommon form of stroke, frequently unrecognized, and greater than old. Female ischemia is not always 3 to 1, but for textbook sake and for MCQ purpose, you please remember 3 to 1. But nowadays is males also, we are seeing more number of cases, right? It leads to the significant mortality and morbidity if you can't diagnose the case within the time, right? So what is the pathophysiology? This is what is Vitreous, right? Vitreous, right? Can anyone tell what is Vitreous, right? So multiple etiological factors are there for CVT. Usual one or more predisposing risk factors plus one inciting factor. One inciting factors will be there. So thrombosis may be developed, right? Thrombosis will develop, and that is due to the common hypercoagulable states, direct injury or inflammation of the blood vessel, right? The blood vessel, that may be a vein, then venous stasis, and this is the vitreous striate, right? Transient and permanent risk factors rise the suspicion for CVT and influence the treatment duration, right? So we should look for the risk factors, and we should look for the etiology, right? So pregnancy and pregnancy, this accounts for 50% of the strokes in this period, right? Infection, central nervous system, CNS infections like empyema, meningitis, right? CNS, empyema, meningitis, ears, sinus, mouth, face and neck, otitis, mastoiditis, sinusitis, tonsillitis, stomatitis, and cellulitis, right? These may be, but very, very rare. Otitis, mastoiditis, sinusitis, very, very rare, right? Systemic infection, sepsis, endocarditis. Endocarditis may predispose to CVT, right? Remember, endocarditis may predispose to CVT, right? Tuberculosis, HIV, and malaria. Okay, tuberculosis, HIV, and malaria. So physical precipitants, right? Head trauma may precipitate any hemorrhagic stroke. Okay, yes, that you most commonly know that. But head trauma may also precipitate CVT, right? Lumbar puncture, myelography, intrathecal medications, right? intrathecal medication, spinal anesthesia, radical neck surgery and neurosurgical procedures, jugular and subclavian catheters, right? Jugular subclavian catheters may also predispose to CVT. Okay. See here, I want to say that otitis, mastocytitis, sinusitis is not that much common, but remember, may cause CVT, right? So these are the drugs causing drugs with prothrombotic action. What is prothrombotic? Prothrombotic. So drugs with thrombotic formation, right? So these factors, these drugs predispose to formation of the thrombus, right? So drugs with prothrombotic action. Please remember these drugs, right? Oral contraceptives. Females who use oral contraceptives, right? They may lead, they may present with CVT. This is a risk factor, right? What is the metabolic enzyme? What is the pathway enzyme for this oral contraceptives? What are the drugs we should be cautiously used while using of oral contraceptives? Which which anti-tubercular drug which anti-tubercular drug metabolize to the same pathway cytochrome P450, and it should not be given with the oral contraceptive, so that this is an enzyme inducer, so rifampicin gets inhibited the activity, so the drug levels in the blood for rifampicin will get decreased, and the tuberculosis will not be responded to the drug rifampicin. Do you understand me? I'm asking, oral contraceptives decrease one drug in the blood because there's an enzyme inducer. So what happens is metabolization will the drug will be metabolized fast. So what happens? The response to the disease by the drug will be less, right? Pharmacology, basic pharma, G pharma, general pharmacology. So what is interaction? Drug interaction. See, remember, drug interactions are very, very important. If you know drug interactions, and as a for anyone who may be a practitioner, or you may be a house surgeon, you may be a final year final year PG, or final year undergraduate, whoever may be, but you should know the drug interactions. Why? Because most of the people you know, or most of your relatives, or any maybe someone may be using 2 or 3 drugs, right? If you know the drug interaction, so you may be cautious regarding the treatment part what they are using, right? Contraceptives with rifampicin, remember rifampicin. So both the drugs, so they have drug interactions that reduces the enzyme inducer of CYP450, right? And reduces the levels of rifampicin. So hormone replacement therapy, steroids, androgens, medroxyprogesterone acetate, L-asparaginase, cyclosporine, remember cyclosporine, tamoxifen, lithium thalidomide, sildenafil. Other conditions, yeah, I told you dehydration and alcohol intake are the major risk factors for CVT, right? Diabetic ketoacidosis. Can anyone tell me what is the criteria for diabetic ketoacidosis? Okay. So please remember these drugs, right? Yeah, and this is the study, and this is a references. These are the references for my study, and this is not actually not my study, but this is a reference for my study. That, see, the association of the alcohol consumption and the occurrence of CVT has not been well established. When this is 2017, by that time, right? But before that, this is actually before 2017, right? But this is the reference I have took. Okay, and based on this reference, I have done my study in this is our medical college, Ashram, right? So 54.54% of the men had significant consumption of the alcohol. One other study from South India conducted by this person showed a similar picture, that alcohol was etiologically related 45.4% of the cases, right? 45.45% of the cases, the risk factor was alcohol. Previously, we were discussing that female most common, pregnancy, postpartum is most common, we have discussed. But I am now telling that alcohol is the risk factor which accompanies most maximum number of cases for CVT, right? And the pathogenesis towards that is dehydration and resultant hyperviscosity, right? So this is the thing I want to show you. So this is the permanent risk factors, and these are the things most common causes of stroke in young, right? Causes of stroke in young. See, genetic causes: protein C deficiency, protein S deficiency, antithrombin deficiency. What is the mutation? Can anyone tell me the mutation of this antithrombin? What mutation? What mutation of this? What mutation number of this causing this CVT or stroke? Remember Z20210, 20210. Okay, 20210 number. G20210 antithrombin, right? And that is the risk factor for CVT. Factor 5 leading mutation, prothrombin. See, these are all the prothrombotic states. Prothrombotic states. So they facilitate to form the thrombus. They facilitate to lead to ischemic stroke, right? So factor 8 excess. Remember that hyperhomocystinemia. Hyperhomocystinemia is a metabolic disorder due to the deficiency of which enzyme? Hyperhomocystinemia. If you look for the levels of homocysteine levels are elevated, then what is the treatment for this patient? Biochemistry, first year. What are the enzymes responsible for the formation of next step, that is homocysteine? Metabolize for homocysteine metabolism. What are the next enzymes responsible? Enzymes, okay. What are the vitamins promoting the pathway of homocysteine? Vitamin B6 and B12, right? Pyridoxine, B6, pyridoxine and B12. So for this patient, if you supplement pyridoxine as well as B12, the homocysteine levels will be decreased, right? So antiphospholipid antibody syndrome is APLA. There will be criteria for APLA, antiphospholipid antibody syndrome. The patient will be present with recurrent abortions, right? Nephrotic syndrome, cyanotic congenital heart diseases. Okay. Which spinocerebellar ataxia is called Lincoln's ataxia? Anyone remember last class? Which SCA, spinocerebellar ataxia, is called as Lincoln's ataxia? What are the clinical features of Friedreich's ataxia? Roll number 46. Present or absent? What are the clinical features of Friedreich's ataxia? What are the causes for extensor plantar response with absent reflexes? Actually, at the time of listening the class, what you will write the notes, or just you look the PPT? Just I want to know. Please, someone speak. See, what are the things? Someone, not only myself, some other professor or some other person may teaching. You will write in the notes, or just you will listen and just you look over the PPT. See, everyone comes here and speaks the important points only. That is the definite thing I want to say. So you should try to write those things, and you should memorize the things, right? So if you don't memorize and if you don't read the notes you're writing, there is no use of the thing what you're following, right? Not only the classes, right? You may read your books, your 7th sem, you may be reading your part SPM, you may be reading your Oftal, right? You may be reading your ENT. Please try to habituate writing the notes, right? If you don't write the notes, and it's the same if you revise the second time, it is same like you are reading for the first time, right? So there will be no difference. You should take the essential points and you should read the notes, right? You should write and read the notes, then only you can memorize. And gunshot points you can write on your examination. and the conceptual points you can able to remember for a long time, right? Otherwise it's different, it's very difficult, and you can't complete all the syllabus at single point of time. So please, if anyone tells any point, so what is what? So I told you many times, extensor plantar response with ankles are absent. See, what are the features? What are the signs of UMN palsy? Upper motor neuron actually. Upper motor neuron. What happens to plantar and upper motor neuron lesion? What happens to plantar and upper motor neuron lesion? Please speak. What happens to plantar, extensor or flexor, upper motor neuron lesion? Roll number 108. Roll number 117. Roll number 70. What happens to plantar response in upper motor neuron lesion? Simple question. Okay. There is no use of teaching you the anatomical aspects, right? Corticospinal tract, anatomy, physiology, I have explained you everything. So please try to read, please try to revise the things, right? Don't, please try to revise. If you revise only, then you will remember, right? So what are the other causes? Malignancies, CNS, meningioma, solid tumors, right? Hematological lesions like leukemias, right? Leptomeninges, carcinomatosis, we will call it as, right? Hematological CVT. Lymphomas, hematological conditions like anemias, sickle cell disease, iron deficiency, folic acid. Sickle cell disease, what is sickle cell disease and what is the difference between sickle cell trait? Pathology. Sickle cell disease is HBSS, two forms. Trait is HBAS, right? HBAS. Paroxysmal nocturnal hemoglobinuria, polycythemia, and thrombocythemia. That means thrombocytosis. Remember, thrombocytosis. Okay. Inflammatory diseases like SLE, Sjogren syndrome, Vigenous granulomatosis. See, remember, Vigenous granulomatosis is the name that we able to pronounce. Or Vigenous granulomatosis is the previously name. So now Vigenous granulomatosis is called as granulomatosis with polyangiitis. Okay, Vigenous granulomatosis is now called as granulomatosis with polyangiitis. So remember G for G. Vigenous G is there. So strawberry gingivitis. Strawberry gingivitis is seen in Vigenous granulomatosis. Strawberry tongue is seen in Kawasaki disease. Strawberry tongue is seen in Kawasaki disease, right? Temporal arteritis, Behet's disease, inflammatory bowel disease, sarcoidosis, right? Endocrine disorders like hypothyroidism. You see, actually, I have seen this one case, hypothyroidism, patient having TSH of 150, right? TSH of 150, patient is hypothyroid, de novo hypothyroid, who are diagnosed at that point of time. Patient presented with stroke, actually. So patient presented with stroke, see, hypothyroidism also causes AF, right? Hypothyroidism also causes hyperthyroidism. Both are responsible for erythemias, right? And atrial fibrillation. Patient have atrial fibrillation and patient embolic stroke. Patient presented with embolic stroke, right? Hypothyroidism, AF, atrial fibrillation, embolic stroke, right? So these are the thrombosis of the cortical veins leading to localized vasogenic edema, venous infarction with cytotoxic edema. So what is the difference between ischemia and infarction? What is the difference between ischemia and infarction? What is ischemic penumbra? Within how much time, if you will not recannulize, or reperfusion to the ischemic penumbra, it will lead to infarction. Within what amount of time, if you are not recannulized or if you not reperfuse the ischemic penumbra, it will lead to infarction. Can anyone tell me that? Please search and please tell me in the next class, right? Thrombosis of the large venous sinuses obstructs venous drainage, impairs CSF absorption to the arachnoid villi, intracranial hypertension without hydrocephalus. When will be your final year exam? When will be your part 1 examinations? Do you have any idea? Jan, February, March. Okay. Intracranial hypertension without hydrocephalus. So these are the cortical veins, right? This is the superior sagittal sinus. This is a straight sinus. Yes, this is the transverse sinus we have discussed it, right? And this is the vein of Galen, right? Vein of Galen. This is the vein of Trollad will be there here, right? Vein of Galen. So this everything. The image what I posted here is based on studies only, right? Most frequent, most common things is this. See, there 624 cases they did a study, and in that study, superior sagittal sinus is most common. In my study also, superior sagittal sinus is most common. Transfer superior sagittal sinus, yeah, out of 40 patients, out of 18 members, not 18 members, 22 to 24 members are having superior sagittal sinus, as well as with involvement of transverse sinus and straight sinus, right? So onset acute, subacute, chronic can be divided into acute, subacute, and chronic. Isolated intracranial hypertension syndromes presenting with headache, vomiting, papilledema, visual disturbances, right? So patient, what are the triad of intracranial hypertension? What is the triad you call for intracranial hypertension? What is the name of the triad? What is the name of the triad you call for you'll see in intracranial hypertension? Cushing's triad. Cushing's triad, right? Focal syndrome. Focal deficiency will be there, right? Seizures, multifocal signs, mental status changes, stupor, coma will be there, right? So headache. What are this? What is this image? Can anyone tell? What is this? Opthal. What is amaurosis fugax? So we'll see headache as raised intracranial tension, focal as generalized seizures, focal motor seizures, encephalopathy, visual disturbances, diplopia, stupor, coma, right? So what is this image? What is this lesion? Everyone able to see this? Everyone able to see this? What is this called? Spotter. Orbital cellulitis,
Yes,
right?
sir.
Thrombosis of the cavernous sinus may produce a characteristic syndrome, that is orbital pain, proptosis, chemosis, and there is involvement of the nerves 3, 4, 5, and 6. Which division of fifth cranial nerve is involved in cavernous sinus thrombosis? So these are the things: headache, raised intracranial pressure, and any focal deficits, papilledema, right? For knowing the papilledema, you should see the fundus, right? So if these are the things you can see, and you should raise the high suspicion for it maybe CVT, and you should go for MRI to rule out the anterior cerebral artery or MCA territory stroke, and then as per protocol you should go for MRP, right? So hematological, that thrombotic profile, you should see any bleeding manifestations or any thrombocytopenia, or CT brain you should do, CT venogram, MRI, MRV, catheter angiography, digital subtraction angiography you can do, right? And in ashram we will do these up to this step, these things. Catheter angio, it is somewhat higher level. We will not do in our case, in our tertiary care center, right? Hematological, you go for thrombotic profile, you should look for protein C, protein S deficiencies, antithrombin. Okay, CT brain you should do. So these are the basic investigations, right? And so recommendations, what they said is that class 1 recommendations, blood work you should do for complete blood count, chemistry panel, prothrombin time, PT, APTT, INR. What is PT? Prothrombin time. What is PT and what is APTT? Intrinsic pathway. To know the defect in the intrinsic pathway, which is used, prothrombin time or APTT? Can you tell me the intrinsic pathway? Coagulation. Which factors participate in, which coagulation factors participate in intrinsic, extrinsic pathway? What is common pathway? Which pathway is long pathway? Which is pathway short pathway? Intrinsic pathway is long pathway. Okay. Extrinsic pathway is short pathway. So remember, intrinsic pathway is long pathway and intrinsic pathway APTT. So this is very long now. Okay. So APTT is marker for intrinsic pathway defects, and this is for extrinsic pathway defects, warfarin, liver disease, everything. If PTINR is elevated, you should suspect that there is a defect in the extrinsic pathway, or there may be defect in the livers, right? Screening for potential prothrombotic conditions that may predispose CVT, like use of contraceptives, we already discussed. Underlying inflammatory diseases, infectious process, we have discussed, right? Management recommendations is that you should test for prothrombotic conditions like protein C, protein S deficiency, and this is a mutation I told you now, G2210, G2210A mutation, factor V Lutein mutation, right? You should check for antiphospholipid antibody syndrome. And what are the antibodies seen in antiphospholipid antibody syndrome? Antibodies seen in antiphospholipid antibody syndrome. Antibodies seen in antiphospholipid antibody syndrome. Beta to glycoprotein antibody, lupus anticoagulant, right? We do not suggest thrombophilia screening to reduce death, improve functional outcome, or prevent recurrent venous thrombosis in patients with CVT, right? Thrombophilia screening may be performed in patients with high pretest probability of carrying severe thrombophilia. That is a patient having personal history or family history or young age of CVT in their family. Then you should go for thrombophilia screening, right? The thrombophilia screening is nothing but protein C, protein S. You should investigate. Okay, if the patient having 35 years patient presented with some weakness, we don't know the diagnosis, we're asking for the history, family history, personal history, and in their family or in the family or any history of having young stroke, then you should go for thrombophilia screening, right? You should go for investigations. That is the thing I want to say here. What is this scan? MRI or CT? What is this scan? See, the cortical bone is hyperdense. So it will be, this is CT, right? In CT, how the hemorrhage looks, how the ischemia looks. In CT scan, the hemorrhage looks bright. Okay, the hemorrhage is bright in CT. Ischemia looks dark or hypo-intense. Hypo-intense in CT. MRI opposite, right? So this is infarct. Maybe some venous sinus occlusion, right? So here see clot sign, dense clot sign. This is clot sign, right? Hyperdense thrombosed cortical veins, right? Hypertension, thrombosed hypertension MCA sign you will see in case of acute ischemic stroke here, actual MCA, and these are hyperdensities are seen, right? So these are the hemorrhagic infarction. This is the cord sign, and yeah, this is the vein of Lebanon tract, right? Able to see this. So this is the empty delta sign, and this is the enhancement of the brightness, enhancement of thrombosed veins, right? And here there is filling defect in the left sigmoid sinus, right? Which sinus is most common for thrombosis? Which sinus is most common for thrombosis? Previously, I have shown you the slide now.
Sinus.
What? Which sinus?
Sagittal.
Superior sagittal sinus, yes. So the sensitivity of the CT venogram is 95%. See, venogram, this is not CT scan. CT venogram can detect. Sensitivity of what is sensitivity? What is sensitivity? SPM of the LND going batch. So what is sensitivity? What is specificity? What is positive predictive value? What is negative predictive value? Hmm? What is sensitivity? What is sensitivity? Simple question. What is sensitivity? A by A plus B, B by B plus D by D plus B, C by C plus A. What is sensitivity? Sensitivity is true
A by
positives.
A plus B.
Okay, sensitivity is true positives or true negatives or false positives or false negatives.
True positive, sir.
Specificity,
True
very good,
negative.
very
True
good,
positive.
very good, true negatives. So see, if any test we are doing for any patient and we are telling that, see, anti-CCP antibodies, okay, anti-CCP antibodies are more specific for rheumatoid arthritis. That means that, so specific means true negative. So that means if anti-CCP antibodies are absent for rheumatoid arthritis, then definite clear cut you can say that there is no rheumatoid arthritis for that patient. Why? Because that is true negative. If it is not there, it's 100% that is negative. So there is negative for rheumatoid arthritis. If it is sensitive means true positive. That means sensitivity of 95% means that, so true positive if it is there, that means if the test is positive, then that is definite indication, then definitely the test is positive means the diagnosis is same. So if sensitivity of CT venogram is 95% means, that means that, so if you see the lesion in CT venography, then you can say that yes, there is definitely thrombosis there. That is the thing I want to say here. Sensitivity of 95%, right? Widely available and quick, right? CT venogram we can do, venography you can do. Less expensive than MRI, less invasive than conventional angiography, provides good visualization of the major venous sinus. Yes, we can see superior sagittal sinus, transverse sinus, inferior petrosal sinuses. We can even see cavernous sinuses, right? Limitations is that some deep structures we can't see, right? And radiation exposure, and if there is any administration of intravenous contrast, we can't able to see, we can't able to appreciate in the radiology about these sinuses, and that are the limitations. This is the CT venogram, right? See, higher level superior sagittal sinus thrombosis, right? Higher level, this is normal. Normal, see how the normal superior sagittal sinus is there. Inferior sagittal sinus, inferior cerebral vein, how the vein of Galen is there, how the straight sinus is there, right? How the straight sinus is. So here there is superior sagittal sinus thrombosis there. Okay. So this is MRI, MRV, MRI images and MRV images, right? You can see here, right? Some thrombotic picture in case of superior sagittal. See here, see Here only here there's a filling is there. Here filling is there, but here filling defect is there, right? And this is flare image. What is flare? Full form of flare. Very higher level. So deep cerebral venous vein thrombosis, right? These are images for DVT, deep vein cerebral vein thrombosis, right? This is catheter angiography. No need for you. Catheter angio is no need for you, right? So coming to the treatment part, anticoagulation. Why? Because see, anticoagulation. That means what is CVT? What is T stands for in CVT? Thrombosis, right? So thrombosis means what we should give? Anticoagulants, antiplatelets we can give. We can't give thrombolytics. We can give thrombolytics also, right? Thrombolytics. We can't give antithrombolytics. What are antithrombolytics? Name some antithrombolytics. Antithrombolytic drugs. Okay. Classification, hematology. Name some anticoagulants. Name some
Warfarin,
anticoagulants. Warfarin, okay.
low molecular weight heparin,
Low molecular weight heparin, very good.
Apparent rapid, apparent rapid,
Okay, heparin, unfractionated heparin, okay, very good. What are the newer anticoagulants?
warfarin,
Warfarin is not newer anticoagulant.
warfarin,
Huh? What are newer anticoagulants? Newer anticoagulants. Name some newer anticoagulants. Name some factor 10A inhibitor, factor 10A inhibitor drugs. Factor 10A, rivaroxaban, apixaban, rivaroxaban and apixaban. See, rivaroxaban, RIVORXABAN, rivaroxaban, apixaban, APIXABN. In that XA is there, no? So you remember 10A factor inhibitors, right? 10A factor, right? Apixaban. Now you are using apixaban for COVID patients, right? For thrombotic states. Apixaban 2.5 mg you are using, right? 2.55 mg based on the CT changes and based on the D-dimer levels, we are giving the patients apixaban so that we can MI, we can prevent MI and stroke, right? Why? Because of coronary arteries, prevention of thrombus in the coronary arteries, as well as prevention of thrombus or prevention of ischemia in case of blood vessels in cerebral blood vessels. So that is the reason apixaban. Apixaban we can't, no need to continue for lifelong, right? In this type of in COVID patients, we can continue for only for 14 to 15 days, 2.5 mg, then we can stop, no problem for that. Okay, right. So anticoagulation is cornerstone of treatment for CVT, prevent extension of the thrombosis and support and spontaneous thrombus resolution. Initial anticoagulation by low molecular weight heparin or unfractionated heparin we should use, and then the goal is that we should. What is normal APTT? Can you say me the normal APTT, right? So if you give unfractionated heparin, see, I have already told you that APTT is the measurement for intrinsic pathway, right? So unfractionated heparin controls the pathway factors, factor 7. So APTT is responsible for the intrinsic pathway, right? So, and we should control, we should look for the APTT levels. If the patient is on heparin, so the patient may, if chronic use of heparin is anticoagulation, so prevention of thrombus, we are making the blood vessel patent, right? So that chronic use of heparin may lead to what? Bleeding, right? So how you can say the patient has risk of bleeding or not? So then we should go for APTT. We should investigate for APTT. If APTT levels are more than 3 times, then you should reduce the dose of low molecular weight heparin, right? Or we should stop heparin. That is the thing. So oral vitamin K antagonist, right? What is vitamin K antagonist? Oral vitamin K antagonist means what? Which drug? 2, 7, 9, 10 are the factors inhibited. What are the factors promoting this promoted by this vitamin K? What is the drug? Warfarin, right? So when you are giving warfarin, the INR should be maintained 2 to 3. Okay. Yeah, this is one study. Here I have shown you that the patient having cerebral sinus thrombosis and some hemorrhagic transformation is there, but at immediate point of time we should not stop giving heparin. See, heparin is the risk factor for bleeding. I told you now. Heparin, bleeding, anticoagulant, okay, bleeding. So, but still there may be hemorrhage, but it is not absolute contraindication for heparin in case of CSVT. Why? Because the thrombus is there. We should treat the thrombus also. Risk versus benefit ratio, we should treat for thrombus. So we should give heparin. So that is the thing I want. Is new asymptomatic cerebral hemorrhage will be there. So we can give. So ICH intracerebral hemorrhage is not a contraindication to heparin treatment. And we suggest treating patients with low molecular weight heparin instead of unfractionated heparin, right? Why? Because low molecular weight heparin, there is risk of bleeding will be less, as well as monitoring. For unfractionated heparin, we should monitor ABTT. For low molecular weight heparin, we no need to monitor that much every time ABTT, right? And second thing is that heparin induced thrombocytopenia we can see with unfractionated heparin. Heparin induced thrombocytopenia. There is a very less risk with low molecular weight heparin, right? Low molecular weight heparin means what? What is the drug? Can anyone tell? We are using it in COVID patients also. Enoxaparin 40 mg.
Enoxaparin.
Ah,
Enoxaparin.
yes, enoxaparin. Enoxaparin, dalteparin, tinchaparin, right? Enoxaparin is most commonly you are using, right? Enoxaparin 40 mg subcutaneous based on the D dimer levels. For any COVID patient, now what we are doing is that we will send the D dimer levels. If D dimer level is elevated, the patient may be having some risk of pulmonary embolism. So we are making that enoxaparin BD, subcutaneous BD, right? Our first stat dose we can give IV, but mostly we commonly follow subcutaneous only. Enoxaparin 40 mg subcutaneous OD is enough dose, but in case of D dimer is positive, there is high risk, so we should go for BD, right? So this recommendation doesn't apply to the patient with contraindication for low molecular weight. See, low molecular weight, there is one contraindication, that is renal insufficiency. If the patient is having more creatinine or known case of chronic kidney disease, then we can't give this low molecular weight heparin. Why? Because this makes the creatinine level some much more higher, right? The EGFR will be glomerular filtration rate will be decreased. Okay, and okay, that is the thing you should remember. Vitamin K antagonist, we should maintain target of 2 to 3 INR. We can continue for 3 to 6 months, right? And this we have already discussed what are the causes and what we should do. This also for thrombo